As with any treatment approach or any therapeutic orientation, it doesn't do everything. Ours does a lot, but not everything. So, we're going to talk a little bit about what it treats around, and what it doesn't treat. So, what it treats are the non clinical concerns of life and some clinical. So, we'll start with the non clinical. This might be stuff like procrastination, it might be stuff like body image issues, disorganization, a case of the life blahs, mood that's kind of like, but not anything huge yet, anger issues, work concerns, poor boundaries, all of this type of stuff. It also works really well with OCD, with phobias, with body dysmorphia. It works well with sexual identity issues of like, what am I, etc., that exploring thing. It works at the realization of authentic self. It works with even some depersonalization. It also treats addiction, but there's a little kind of asterisk on that one because with active addiction, we first want to get our client to a stabilization point. So once they're there and they're not in detox mode, protocol works beautifully with it. Same sort of thing for eating disorders. We want to get them medically stabilized generally so that we can do the thing safely. The other thing that it works beautifully for is suicidality and self harm. Now, again, we want our client to be safe and stabilized first. So there's a little check in with some risk assessment stuff that would need to be done before that. But it is a really, really, really successful method for addressing suicidal ideation and suicidality or the reason for past suicide attempts. And there's a complete list in Shift Academy. What our protocol helps with but doesn't treat are psychiatric concerns like bipolar disorder 1 and 2, ADHD, and uncomplicated grief. And we'll talk a little bit about why this is. So, ADHD is a neurodivergency, right? We can't go in and change the way the brain is structured in our clients. Why we say we do work with it is because we treat all the fallout and the collateral around it. So, often when people come in and they've got a diagnosis like that, there's a bit of shame or there's some past history of, having negative experiences in school or at home, being misunderstood. And those encode the limiting beliefs that we can move away. And then we're able to get our client to be able to message what they need from their relationships, from their work settings, et cetera, et cetera. Same sort of thing goes for bipolar or any of the psychiatric concerns that we will treat around. We want them to have a bit of psychoeducation and understanding, but we want to treat that collateral fallout that having a diagnosis that's difficult or psychiatrically significant has for our clients. Same sort of thing when we get into gender identity disorder. We treat around it because we don't know what the client wants to arrive at, right? So we just will deal with a lot of the stigma, a lot of the negative experiences that they might have had around their gender identity. So we deal with that. We're not trying to change their gender identity one way or the other, and we're not trying to enable or substantiate any particular view. So it's very autonomy focused. Uncomplicated grief, also something that we're going to want to have some room for because we definitely see it in our client population, but you can't make grief go away. We can make sure it stays in the realm of uncomplicated grief instead of turning into complex grief, which is the grief that gets stuck based on certain limiting beliefs or other collateral experiences. So we do work with that. And there are a number of things, and like I said, the complete list is in the handbook and on Shift Academy that we don't treat. So one of the things that we don't treat is similar to the ADHD stuff. We don't treat learning disorders and disabilities. We don't provide strategies for them. We don't work with them directly. We will work with the collateral around them sometimes, but we can't fix somebody's dyslexia. That's not how it works. The other thing that we don't treat is severe and active psychiatric concerns. So if we're having a client come in with a lot of hallucinations or paranoia, etc., some of the symptoms of really active and untreated schizophrenia, we're going to want to refer them to their family doctor or their psychiatrist so that they can get stabilized to a point, and we're not those people for that. The protocol doesn't really work with treating the origin of those types of psychiatric concerns. We also don't work with a lot of assessments. We'll work with ADHD assessments a little bit, but We're not super diagnostically focused. We just want to treat the origin of the problem. And there's another one in there as well, gender transitioning. And one of the reasons for this one is that due to the complexity of the medications and the psychological impact in gender transitioning, we have it as out of the bounds of our competency to treat. So, one of the things we can do though is if we outline as psychologists that we have a limitation to our competency in this area, we can still work with some of those things around the gender transitioning. And that's something that you probably want to consult on or develop a specialty in so you don't have a disclaimer to your competency level. So, something to keep in mind there. There are a few kinds of things like that with non medically stabilized concerns, whether it's anorexia or addiction, like I mentioned, that we don't work with. Large berth of things we do, some things that we don't. And if you're ever confused, just reach out to one of us or check in the handbook, and we've got a little bit more of a comprehensive list there.